I'm Anthony Leeds, and it's my pleasure to welcome you to the eighth and the last of the series of conversations that we've been holding over the last few weeks. And it's my pleasure to welcome Professor Mike Lean from the University of Glasgow, who is going to be able to tell us something about the 5-year results for the direct diabetes remission trial, and also about the recently published European guidelines for diabetes management. So Mike, welcome. Thank you very much for joining us. Perhaps you could begin by just telling us what we know so far about the 5-year results for direct, bearing in mind that some viewers may not be familiar with what was done overall, so we may need to provide a little bit of the background to the whole study.
Yes, thank you, Tony. I'm very pleased now to be able to begin to tell people what we have found after 5 years. The background to this is the DIRECT was a randomized controlled trial which lasted for 2 years, which actually is a very long time to have patients following a diet program in which they lost quite a lot of weight. And the aim of this was to get free from diabetes. They had type 2 diabetes at the beginning, and at 2 years, a high proportion were still completely free from diabetes, not requiring medication for 2 years. And that's changed practice in Britain, in Europe, indeed across the world. But the big question is, what's going to happen in the future? It's all very well having a remission of diabetes for 1 year, for 2 years. How many of these people can keep their remissions, and what's going to happen? So what we found, and the results were presented at the Association of Physicians and at Diabetes UK's professional conference last week. And what we found was that the people who were in remission at 2 years, a quarter of them were still in remission at 5 years. And that's really quite a striking finding. Overall, we assumed at the beginning that all those who had remissions at 2 years would no longer be in remission after 3 years. And that was just not the case. Over 10%, over 1 in 10, 15%, but 1 in 7 people were free from diabetes. And that's of everybody who started the program. And those who relapsed back into diabetes, most of them were only just diabetic, and a lot of them, indeed 40% of all of them, did not require medication for 5 years. That's a big change from conventional management of diabetes. So the weight loss was maintained by a very simple low intensity program of 3 monthly visits to the either the practice nurse or a dietitian, if there was one, who basically gave our patients a pep talk every 3 months. And with that, they maintained a weight loss of 6 kilograms from baseline for a total of 5 years. That's the average. Of course, half of them did better than that, and half of them did less well. And we've got a big task ahead. We know now that losing weight, a substantial amount of weight, is going to get freedom from diabetes. It's going to allow them to remain off medication for diabetes and for high blood pressure, hypertension. The big question now is, how are we going to be able to maintain that in the longer run? The second question which arose after the DIRECT results was whether the weight losses and the remissions of diabetes that we've recorded would translate into protection against the complications of type 2 diabetes. Now, when I was a medical student or a young doctor, we were mostly concerned about type 1 diabetes. And to be honest, we almost ignored type 2 diabetes. We left that as something which happened to older people, and we just gave them a pill and basically did not much about it. Now, what's happened in the last 20, 30 years is that type 2 diabetes has started in younger people because they're more overweight, and in much younger people. So we're now seeing an average age in Britain of around about 50, 52 years. And of course, in Asian countries, it's much younger than that, and with less severe obesity, a lower body mass index. So we're now seeing type 2 diabetes affecting much younger people, and they are getting complications. And this is the tragedy, because this is a disease which we had really not taken too seriously when it affected much older people over the age of 70 or 75. It's not going to do too much damage. But if it affects 60-year-olds or 50-year-olds or even 40-year-olds, it's going to do a lot of damage. And this has really become severe diabetes. So getting a remission is that going to do anything to protect against the complications of this disease? And as you know, it affects just about every organ in the body, notably the eyes, the kidneys, the nervous system, the heart, and even dementia is now being recognized as a complication, plus all the infections, aggravated infections, and we saw this in COVID. So the DIRECT trial, 5 years on, we were able to look at the clinical complications. The study was not big enough to be absolutely definitive. We're going to need to observe people, more people over longer periods when they get remissions. But what we found was that the people who had the intervention, who lost weight, and many of them got remissions, they had fewer serious adverse events. And serious adverse events mean admission to hospital with a medical problem. Basically, so that meant that they had less of the severe medical complications which we see more commonly in people with diabetes, and that included several cancers, which we did not see in the people who had the intervention. So the control group had more serious adverse events. The intervention group were protected against that, and that included several cancers which we saw in the control group, who were managed with very good guidelines, all the medications that we normally give to our patients, but they did not have the intervention. So that's an important signal and something which we need to follow up in bigger numbers. If we can prevent hospital admissions, then we reduce costs and all the domestic and social disruption of diabetes. If we can, by the same intervention, reduce cancers, then that's a major step forward. And we know that people with type 2 diabetes have more cancers, a variety of different weight, obesity-related cancers. So that's good news. The intervention does give a signal that it appears to be reducing the complications of diabetes and the severe ones, leading to hospital admissions. As I say, we need bigger numbers to be sure that this is a causal relationship. The people who did better, who got remissions, tended to be more health conscious anyway, so everything was in their favor. Now, we also were able to look at the perhaps less serious or not life-threatening complications of diabetes, which are much commoner, and that includes infections, it includes vascular events, it includes eye events, kidney events, and such like. And we put together a group of these complications of diabetes, which we called moderate and major diabetes-related adverse events. And again, there was a signal that the people who had a lower hemoglobin A1C, who were able to remain off medication and who got remissions at different points in the study, were relatively protected against the wider group of diabetes-related adverse events. So we can't say for definite that people will, as in any individual, will be free from complications, and I think that would be rash in any branch of medicine or science. But we can say that if this intervention is given, routinely to large numbers of people, then the ones who follow the intervention and who do well are likely to be the same people who will be free from hospital admissions, severe or serious adverse events, and from the complications of diabetes. So this is, an important step forward. We've got better results from this dietary intervention than I think any drug trial has achieved, even the very big ones. So it tells us again that weight management, weight loss, is a very potent medical treatment. It's a more effective treatment than taking pills for your diabetes. It's a more effective treatment than taking pills for your high blood pressure. And it's beginning to translate into a relative protection against the further complications. So it's really pretty good news.
Good. So what is the next step? I mean, what would you, given adequate resources, what would you like to see done next? What would you do next?
I think the evidence is now so secure, and this is not the only study which has produced similar results. We have the Diadem 1 study carried out in Qatar, in Arab and North African people, which produced almost identical results to DIRECT, with remission rates up in as much as 60% at 1 year. We conducted a study in Glasgow of people with South Asian ancestry, mainly Pakistani origin, and they had exactly the same results. And in both of these studies, we find that there was an excess of fat in the liver, fat in the pancreas, and it seems to be the fat in the liver which accumulates, and that triggers a series of events which lead to diabetes. So what we found was in each of these studies, weight loss of the order of 10-15 kilograms, if possible, would remove that damaging fat from the vital organs, particularly the liver, and it would then get a remission of diabetes. So we know that's true. So what we would do next, I think, is that we should be offering this treatment to everybody. I think it should be the first stage in managing diabetes. As soon as you discover diabetes, somebody discovers a diabetic, they should make every effort to get free from the disease, get a remission for as long as possible. And essentially that means losing as much weight as possible and keeping it off for as long as possible. Now, you will also then ask, what about the people who are not very overweight, who are, not obese in the common terminology? But that we usually mean in Europe or North America, we mean body mass index of 30, or perhaps in Asian countries, a body mass index above 25 or 27. And the point that we've discovered is that people who have type 2 diabetes, who have a lower body mass index, which might be 23 or 24, still have too much fat in their liver and in the pancreas. And if they lose weight, their diabetes gets better, just like the more overweight, the more obese individuals. So the message is really pretty much the same. If you have type 2 diabetes, you are at least 10 kilograms too heavy, and that has provoked deposition of fat in vital organs, particularly the liver. To get clear of the disease, you have to lose somewhere in the region of 10 kilograms. Now, if you are much more overweight, and this really is more to do with the European and North Americans who may have a body mass index of 40 or even 50, they will very likely get a remission of diabetes by losing 10 or 15 kilos, but it's very likely that they will then need to lose more weight in the future. And we're beginning to think that, the old concept of an ideal body weight, which was somewhere around a body mass index of 21, was actually probably ideal. And we've been lured into accepting a body mass index of 23, 24, 25, which I would be very uncomfortable if I had a body mass index of 23 or 24. We've kind of accepted that as normal, and it simply isn't normal metabolically, at least not for large numbers of people.
Yeah, and of course there's been the drift upwards, hasn't there, in BMI in almost every population in Europe and North America and Australasia and so on, and elsewhere in other parts of the world.
And that drift up in the body mass index has been has had a greater effect, a more adverse, a more damaging effect in people in Asian countries and indigenous people, both in North America and Australia and such like, where there's a much greater susceptibility to the damaging effects of quite modest weight gain in many cases. So that drift up in the population, it's been quite rapid drift up over 20 or 30 years, has had enormous damaging and lasting damaging effects. And we don't really have any solution to it. We can give pills, we can modify the consequence of type 2 diabetes, but even with all our medications in Europe or North America, people are still dying 5-6 years younger on average. And for younger people under the age of 40, they're probably dying 10 or 15 years younger because of complications of diabetes. That's despite all our treatments. So achieving a remission, aiming to get clear of diabetes for as long as possible, it really is the number one management target now. And that's being recognized increasingly around the world. It's being recognized by people with diabetes. For example, the diabetes organizations in different countries have recognized that having no diabetes, having a remission of diabetes, is far and away the most valuable state to be in, rather than having diabetes and taking pills. So there's been a call for this from people with diabetes to improve medical services to make a treatment for remission possible, and it's now getting into guidelines.
Yeah. So in fact, the European guidelines were published about two or 3 weeks ago, weren't they?
Yes. This has been a mammoth piece of work in Europe, looking at the dietary management of diabetes in every respect. And we did it before. In fact, I've done it on about 3 or 4 occasions now, to develop guidelines where we review the totality of the evidence about different diets and different diet constituents and nutrients, and what's going to improve health for people with diabetes. This set of guidelines, which was, as you say, published about last month, 4 weeks ago, has broken a bit of new ground. It has certainly now included a very important section on weight management, and it's put this right up the agenda with the aim of remission of diabetes and outlining the evidence which says this is possible and how to be able to offer that to our patients. or indeed for patients who will read these guidelines to be able to go to a doctor and say, this is what I want. And that's a hugely important thing. We had to use the published evidence, and for that the best evidence came from studies which used formula diets, and these were all in European and North African populations. And the formula diet is used for a relatively short time, perhaps 2 or 3 months, in order to induce quite a substantial weight loss of 10 or 15 kilograms. And that seems to be the most efficient way of doing it. But in point of fact, we know from other sources that losing weight by any dietary means will probably have equally good effect if you can do it. So if you can lose the weight and keep the weight off. So the guidelines, European guidelines, make the point very, very clearly that the weight loss, possibly using a formula diet, is only for a relatively short period of time. It's 8, 10, 12 weeks. And at that point, we then have to introduce a new type of management, which is for weight loss maintenance. It's a different concept where we're not trying to get people to lose, but to maintain that lower weight and not regain their weight. And there are many ways of doing that. The research is still ongoing, and we don't have the best answers or all the answers yet. But we know, for example, that dietary advice, quite conventional dietary advice, using foods which are easily accessible, not weird or unusual foods, can be very effective for large numbers of people. We know that time-restricted feeding or the sort of intermittent fasting diets can be effective also. And we know that using the meal replacements or periods of total diet replacement is another way of doing it. So there are many different ways that individuals can find, and they need to find one which will suit themselves so that they never regain the weight. Now, that's an aspiration. I'd love to be able to say that we avoided all the weight regain in direct. We didn't. People did regain weight. People, are subject to all the advertising of food industry and the clever social marketing that has been going on for decades now. So it's very hard not to gain weight. But if people are committed and have good advice, then they can do it. So the guidelines have looked at weight loss and at weight loss maintenance. They've also taken the sort of broader view of nutrition to say, giving advice about nutrients, whether it's fat and carbohydrates, and there isn't much to choose between them, I can tell you, or whether it's micronutrients, becomes confusing to people who are actually eating food and eating, indeed, not just even foods, but meals. And so the guideline has actually broken new ground by saying that we will make recommendations based on the evidence, which says that eating patterns are really the most effective and reliable way of helping people towards better nutrition. So it's not to do with having higher carbohydrate diets or lower fat diets, although that is part of the story, but it's more to do with finding a pattern of eating which will suit you, your family, your friends, and allowing that usually a traditional dietary pattern to become your norm. That is based on evidence that, for example, vegetarian diets, which are normal in much of the world, can be very beneficial in helping people to avoid weight gain and diabetes. Mediterranean-style diets, which have a lot of research evidence now, can also be effective in maintaining a lower body weight, in helping people to avoid type 2 diabetes, and indeed in moving towards remission of diabetes and preventing it in people at high risk. And that is very similar to a traditional Japanese diet. We've even got dietary studies in Asian countries now using, again, traditional foods. Dal is a lentil-based meal with rice. And if you have the right amounts, the correct portion sizes, this is a traditional meal which was associated with good health, freedom from diseases like diabetes for centuries. So we can actually, if we can persuade people to celebrate traditional diets, that is one way of then helping them to avoid the temptations which come from heavily marketed foods and packaging and manufactured foods. And these are the ones which have triggered the weight gain and the diabetes across the world.
So there are a number of options. So now for the people listening who might know that they're in a family in which there's a history of diabetes and who may be aware that they're a little overweight, what are we going to actually advise people to do?
Well, I think anybody who is in a family where there is diabetes, and by that we mean in parents, grandparents, brothers and sisters, uncles and aunts, they are at much greater risk of diabetes. It's quite heavily familial. We don't know a lot about the genetics of it, so there isn't any simple test that we can do to tell whether somebody is going to get diabetes or not. But if they are in a family where there is diabetes, then it becomes much more likely. If it's a parent, or even worse, two parents, then it's a very high likelihood. If it's a brother and sister, again, very high likelihood. And it is preventable. We know it's preventable because for centuries, people with the same genetics, the same families, did not have diabetes. And what's different is that they've now started to put on weight. So we know, and we know this from experimental studies, that if we take people who are at risk of diabetes and help them, support them to lose weight and not put on weight, then they don't get the diabetes. And this has been done in people who are already on the slippery slope, who have pre-diabetes. And you can now test with a blood test, which we can do for hemoglobin A1C, which can tell you whether you have pre-diabetes. And that is a sort of period, usually of a year or two, perhaps 3 or 4 years, before finally becoming diabetic. And that gives people at least a degree of warning that this is they're on this pathway. We can take people like that and introduce a weight loss of around 5 or 6 kilograms, and that is enough to prevent most type 2 diabetes developing over the next 4 years. So, it is all down to the weight, and it is all down to the foods we eat. Physical activity, of course, plays a part, but not a very big part. Physical activity is helpful in people who want to maintain a lower weight if they're able to be more physically active. And basically, we're talking here about leg use, so walking, running if you like running, cycling, using your legs basically for more hours in the day than is conventional or habitual for most people. So that does help, but the big push has to be on the food consumptions, because food consumption can overcome physical activity for people who are genetically or familially prone to weight gain and diabetes.
Yeah. Okay.
We can identify people at high risk by their family histories. It can also be done with a blood test if you have access to that. It can be measured, and you can see if you have pre-diabetes. And that's actually the same test which is used to diagnose diabetes. So very often a doctor will measure the hemoglobin A1C and be able to say, you have diabetes, or you have pre-diabetes. And he may say, you're clear, you don't have either of these things. In all of these cases, if you're a bit overweight, the best measure is to lose some of that weight, because there is always the risk that it'll progress. It's a progression over time. And if you are a bit overweight, come back in 5 or 10 years, you might well have progressed to one of these conditions.
So we should add that in the text underneath this video recording, there will be web links to some of the sites in the different countries which enable you to assess your actual risk of developing diabetes, and then lots of other links to other sources of information. So Mike, thank you very much for talking to us. As I just said earlier, this is the last of the series of 8. So thank you very much for participating, because I know you've participated in a number of them, and I hope to come back to you again in the future. Thank you to all the viewers who've watched this, and there is a very loyal audience out there actually who seem to be attending in rather large numbers. So thank you for watching. We're going to take a break now of a couple of months, and we will return with new information in the fullness of time. So hope to see you then. So thank you very much for listening. Thank you, Mike, for participating.
Hoping also that we might be able to tell you some of our results from a little pilot study we're doing in Nepal using a traditional diet there, which is going very well. Thanks to my colleagues in Nepal, we hope to be able to have some results very soon.
Yeah, that would be good. So let's aim to do that perhaps at the beginning of September. Very good. So thank you very much. So I wish you well. Thank you. Bye-bye. Bye. Bye.